Okay, so now for part two. This one's pretty long, so I'll try to go fast. So this section is on how bones, or this part of it is on how bones develop, like from fetal development, and then how they heal. That's most of what this part's on. So ossification is the same as osteogenesis, and you can guess what that term means, and you should really dig into the roots and stems of these words because that'll help you understand it better. So osteo is bone, genesis is to make, so that's bone formation. You start to make the bony skeleton 2 months in utero, at 2 months in utero, and then you're still gonna be growing bones after birth. And then all through life, while you're growing, you're gonna be changing and remodeling bones. So they're very adaptable to like what your needs are. Okay, so at week 8 in the fetus, you mostly have the cartilage, and we'll look at a picture of that in a minute. So you have endochondrial ossification and intramembranous ossification. So most of the skeleton is the endochondral one, where your cartilage is turning into bone. And then some of it is just from fibrous membrane, but most of it's going to be cartilage turning into bone. So endochondral, it forms the bones inferior to the base of the skull, starts at about 2 months, like the fetus is 2 months old. You have to have hyaline cartilage first, and then it kind of gets replaced by bone. And here's the 5 main steps. So you have a bone collar that's going to form around the diaphysis. So remember what that is from the last part. And it's going to start to calcify, and then you'll get a little periosteal bud, so like the periosteum that forms on the outside. And that's going to lead to spongy bone forming, and you're going to start making those stem cells, right? The osteogenic stem cells, and then osteoclasts. Then the diaphysis is going to get longer. You're going to get a little cavity forming so that you can have like a space for the bone marrow. And then epiphyses start to ossify. So here's what it looks like. You start with the cartilage, and then it's going to form like a little hole inside, and that's where the spongy bone's going to form. And then you start to form a little hole on the ends, and that's where you're going to get your spongy bone on the ends. And then you're getting this cartilage that forms on the outside, and then right here's your growth plate. So this is week 9 of fetal development, and then you have month 3, and then at birth, this is what it looks like. So it's still pretty soft. And then as they grow, it's going to get more hardened. So that's why like little kids will get green stick fractures, and their bones are like a little bit like softer, more flexible. So maybe they don't break a bone when an adult would have. And then the intramembranous ossification isn't as common. So it's like in your frontal, parietal, occipital, and temporal bones of your skull and your clavicles. And the steps are you have these mesenchymal cells, and they turn into osteoblasts. And then remember osteoid, that's like the stuff, the substance. You start making some osteoid, and then the bone starts to form from that. So here's what that looks like. You've got some osteoblasts, and this is just connective tissue interspersed there. It's not cartilage, it's just connective tissue, and you get some osteoblasts, and then it's going to make an osteocyte, and you're starting to make some osteoid right here, and then eventually it looks like a bone. So just certain bones will do that process. Okay, and then after you're born, so postnatal bone growth, you're still your bones are still growing, they're getting longer. You've got growth plates that are growing. They're going to get thicker. So you're still doing a lot of growth through adolescence. So in your long bones, you have interstitial growth that requires epiphyseal cartilage at the growth plates. They stay constant thickness, but then you're going to grow cartilage, and then it's going to add bone to it. And you've got 5 zones: resting, proliferation, hypertrophic, calcification, and ossification. So resting zone is the cartilage that's right on the edge of the plate, the epiphyseal side, and so that's where there's not a lot of mitosis happening. And then proliferation is right next to that, and the cells are rapidly growing and they're going to be moving outward. And then hypertrophic is the cells are a little older, and these are the ones like they're moving through this area. And the lacunae are getting bigger, they're forming interconnecting spaces. It's starting to look more like bone. And then calcification is when the cartilage is going to calcify. The chondrocytes, which are the cartilage cells, are going to die, and it's going to be replaced with cartilage. And then ossification, the chondrocytes go away, and they're replaced with osteocytes. And this is also where remodeling is going to happen if it's needed. So this is showing you a growth plate right here. And if we zoom in, this is the resting zone up here. It's really nice to have pictures because that really helps to understand it. And then you have your active mitosis here in the proliferation zone. Hypertrophic is they're a little older and they're getting to look more cartilagey. And then calcification is when those chondrocytes are being replaced with calcium, and then ossification up here where it's starting to look more like bone. So that's all zoomed in right here in the space. That's what's happening at the growth plate, like in kids. At the end of adolescence, it's slowing down. The plate thins. It's going to get hardened, so it's not as like cartilagey anymore. It depends on the person, but females a little bit earlier and males a little bit later. But this can, like, this is a big range. This can go a lot later. I just skipped a page, so I don't know what that said. So make sure you look at that page. So this is showing bone growth and remodeling, and then after growth and remodeling, so it grows outward, and you can see those cells are going to move outward to the tip. And the bone is going to be constantly remodeling. So here it got thicker, right? And then here it kind of like reshaped from the original, like this part got cut out. You can see my mouse. And that's because of those osteoclasts that are going in and remodeling and changing to whatever the person needs, like whatever your muscles need and whatever your body shape is going to be and the weight that you have to support. Hormones also help to make your bones grow. So if your hormones are messed up, that might affect bone growth. But one really important one is growth hormone. That's going to help your bones grow correctly. And then your thyroid also plays a role. And then testosterone and estrogen at puberty, when that hits, that's going to cause growth spurts. And part of that is your bones growing. So if you have anything off with these hormones, any of them, that can cause problems. Okay, so bone remodeling, you are recycling 5 to 7% of your bone mass every week. You're destroying bone and you're creating new bone. Spongy bone, not as often, or not very quickly, so 3 to 4 years. Compact bone every 10 years. I think that means like the entirety of your spongy bone mass and the entirety of your compact bone mass. So like there's a lot of remodeling that you don't even realize. Like most of your cells that you have right now today are not the cells that you were born with. So for bone remodeling, you make bones, that's bone deposition, and you absorb or resorb bones. So both are happening hand in hand. They're both like two sides to the same coin. This occurs at the periosteum and endosteum. And you've got osteoblasts, those are the building ones, and osteoclasts are the breaking down ones. So resorption happens by the osteoclasts. They dissolve the bone. They release calcium into your blood. They do this by releasing enzymes and H plus ions, protons, which makes it an acid. And so that's going to break down your bones. And hopefully they don't do it too much, cause osteoporosis. So they phagocytize the dead osteocytes. Phagocytize means they eat them, just like macrophages eat cells, like eat bacteria. So they digest them and then they release the calcium into your blood. And then the osteoclasts are gonna do apoptosis, which we've learned about. That's when cells have programmed cell death and they self-destruct. To work, they have to have parathyroid hormone. Parathyroid hormone is the hormone that you have parathyroids in your neck. They're on the back side of your thyroid. You have 4 of them. They regulate calcium, and so that's why they're involved with bone resorption. Then bone deposition happens by your osteoblasts. They are the bone building cells. They're going to take calcium out of the blood and form new bone cells, and then they're going to turn into osteocytes. So here's some things that can cause osteoblasts to make new bone. So mechanical signals, like if you're using your bones, like if you're running a marathon or you're building or whatever, you're active, you're physically active, you're using your bones a lot in a really repetitive way, that's going to cause your bones to grow, to get bigger. And they're constantly remodeling. I think it's pretty cool, actually. If you have more calcium in your blood, that could cause bones to develop. If you have these certain proteins that bind, that's going to stimulate your bones to grow. And then if you have this alkaline phosphatase enzyme, it's going to also cause your bones to grow. Okay, so remodeling is that back and forth between your osteoblasts and osteoclasts, and there's genetic factors, and then there's two like negative feedback loops. Actually, I think that mechanical stress would be positive feedback. So negative feedback, if you don't have enough calcium, your osteoclasts are going to break down bone to up your calcium level. Like it's going to phagocytize, kind of cannibalize your bones to get more calcium into your blood because you're not eating enough of it. Calcium is super important in your body, helps with nerve transmission, muscle contraction, blood coagulation, like everything. Like it's really, really important. There's a lot of calcium in bones, obviously, and we need vitamin D to absorb calcium, so make sure you're getting enough vitamin D. Vitamin D is like a super vitamin, really, really important. And then response to mechanical stress is going to cause your bones to remodel, like I've already talked about. These are some hormones that are going to control, like I said before, your bone remodeling. So parathyroid, that is the hormone that regulates calcium. So if you have low calcium, you're going to produce more parathyroid, and that's going to stimulate your osteoclast to break down bone. And then once it's high enough, then you're going to stop making parathyroid. And so it's a negative feedback mechanism. And then you have calcitonin. If you have, these are produced by some of the cells in your thyroid, which is right next door neighbor to your parathyroids. If you have high levels of calcium, you're going to produce calcitonin, and that's going to cause you to break down less bone. So these kind of work oppositely, both negative feedback though. So here are your, what are we doing? Parathyroid, these are your parathyroid glands. Your thyroid gland sits right here on your neck. It's like a little bow tie. And your parathyroids are on the back side of it. So this is looking at the back side of your thyroid. And these are going to produce parathyroid, and that's going to cause your osteoclast to eat up your bone until it falls into the normal level, and then they'll quit. Okay, you can have problems if you don't have the right amount of calcium. So hypocalcemia means you don't have enough calcium. Hypo means under, and then hyper means too much. And both of these can cause really bad muscular problems because you need calcium for your nerve impulses to work and for your muscles to work. So your body's going to work pretty hard to keep these in check by chewing up or building bone. Okay, some other hormonal controls that are going to affect bone density is leptin. That's released by adipose tissue, which is fat tissue, and it inhibits osteoblasts. And then serotonin helps us with mood and sleep. It's a neurotransmitter. It's also going to mess up osteoblasts, so it's going to slow bone development. It's made in the gut. It's secreted after a meal. It's going to lock in calcium and not let your osteoblasts make bone. I'm going too long. So then mechanical stress, however you use them, you're gonna grow more bones. So that's Wolff's law. Bones grow and remodel in response to the demands. So if you're doing unhealthy things with your body, like if you're not lifting correctly or you have bad posture, your bones are gonna grow to respond to that because that's what they do. So make sure that you're treating your body well. What is this? So bending stress. Your bones are super strong, but they are also, like, you can also break them, obviously, but they are really, really cool structures. Okay, so here's Wolff's law, like handedness, you're gonna have stronger bones. Like right, if you're right-handed, your right wrist is probably gonna be a little bigger and things like that. You've probably heard of that, but that is actually a law. And they've looked at why it happens and what's happening to the bone cells. You might have bony projections sticking out if you use certain muscles more, like weightlifters. People who are bedridden are going to have different structures. People who use their feet in certain ways, their feet are going to change shapes because of that. So it's pretty cool. So mechanical stress causes them to remodel, compression and stretching, tension, all of that's going to cause your bones to die or be built. Okay, now for fractures. So fractures in youth usually happen from like a trauma, and then in old age they can happen more easily because your bones are thinning, because your calcium is being eaten up. So there's different ways that we like describe or classify fractures. They can be non-displaced or displaced. So are they in alignment? Are they still in the same position, or are they out of alignment? Complete or incomplete? Did they break all the way through or not all the way through? And then are they open or closed? Open or compound is a synonym, and that's when the skin, like when the bone's sticking out of the skin. And then closed, simple, is when the skin is not open. So here are some different ones. Comminuted is also, I've heard it also called, like sometimes these are together. These are comminuted or compression. You see them kind of together, but they are different. So comminuted is like many pieces. Compression is the bone is crushed from like severe like force. Spiral is a twisting force. Epiphyseal is on your growth plate, really common in kids. So depression is like pressure pushing inward. So that's pretty rough. Green stick is common in kids, and that's when it doesn't break all the way because their bones have more cartilage and they're softer. Okay, so if it is a closed fracture, they're going to do reduction, which means they put it in the right place if it's like misaligned, and then if it's open, they're definitely going to use pins and wires. Then they're going to immobilize, and you're going to have it in a caster or whatever. There are 4 steps to fractures repairing. First, a hematoma, like a blood clot, forms. Then you're going to have a fibrocartilaginous callus forming, and then a bony callus, and then the bone remodel. So this is like pretty logical. Like I think if you were to sit down and think about how a bone would heal, this would make sense. So hematoma is like a clot, and all of these steps are going to stabilize the bone. Like that's the purpose of these steps. But then often we need medical intervention to make sure that the bone is positioned correctly. But your body is naturally trying to like cast the bone and stabilize it. So you're going to get this blood clot. It's going to be inflamed, and the purpose of the inflammation when you break a bone is to keep it immobilized, to keep it stabilized. But it just might be in the wrong place, right? We need medical intervention to put it in the right place. So there's your hematoma, and it's just like all the guys that need to be there are like on the scene, ready to go, ready to help, ready to heal the bone, and then it's stabilizing it with inflammation. Then you're going to make a fibrocartilaginous callus. So you're growing capillaries from the hematoma. You're having phagocytic cells clearing the debris. And then you're going to start making collagen fibers in like a matrix. And then that's going to start to form like a little cartilage area, like a clump of cartilage. Oops, I skipped it, but you can look at that. Whoopsies. I think I have a picture of all 4 in a little bit. Then you're going to form a bony callus, and so some of that cartilage tissue is going to be ossified. That takes a while. This is why you're in a cast so long. And then finally, so you're going to have like a bulge of bone that's not shaped right. And then finally, you're going to go into, so there's your bulge. Like this is not the right shape. This did not heal correctly. You need to do some bone remodeling. Like you need to trim and buff and get everything shaped right. So that's the bone remodeling part. That's when your osteoclasts are going to chew up the bone and make it work right. And to do this, you need to use the bone so that they know how to remodel. If you don't use it, then it's not going to remodel right. And so that's what response to the same mechanical stressors means. So if you use it and you do physical therapy or whatever, then it's going to be formed right. So there's the remodeling, and it's never going to look exactly the same, but it should be like pretty strong, just about as strong. Sometimes people will notice like a bulge or a bump where that fracture happened. So if you've had that, you might notice that. So here's all the steps: the hematoma, the fibrocartilaginous callus forming, and you can see it's vascularized, and then you've got your bone replacing it, and then you've got your remodeling. Okay, so here's some bone disorders: osteomalacia or rickets, osteoporosis, and Paget's disease. So osteomalacia is your bones don't have enough calcium; they're not mineralizing correctly, so that you get soft, weak bones. And then in children, it's called rickets, and this is like not very common in the United States anymore, but used to be more common. They get like bowed legs, you know. They don't grow right. They're going to have deformities, and this is from a vitamin D deficiency or not enough calcium. You need vitamin D to absorb calcium. So one or the other, you're going to be limited on calcium. Like if you could have all the calcium in the world, but if you don't have vitamin D, you're not going to be able to absorb it. And then osteoporosis, there's a few different types, but this is when your bone becomes like you are losing bone mass and your bones become kind of holy. That's why it's called porosis, like pores. So osteoporosis. So especially your spongy bone in your spine and neck, and it causes hip fractures. This is most common in women because of estrogen, actually. So that's a really rough disease, and it can be prevented. Like we said, you can build more bone through use. So if you're exercising when you're older and eating healthy and taking vitamin D and all of that, that can help. So this is what osteoporosis looks like. This is a healthy trabeculae, and then you can see the little holes there. So the osteoclasts have, for some reason, have chewed up too much bone. So risk factors for osteoporosis: postmenopausal women affects 30% of women from 60 to 70, 70% by age 80. So it's almost inevitable, but there are things that you can do, like exercising, like we said, and eating healthy. And estrogen is a big player in that. Males are less prone because they are exposed to more testosterone. Everybody's exposed to the same hormones. We're just like more or less of each one. Other risk factors: so not enough exercise because you need to use your bones, poor diet, smoking, genetics, and then other issues like hormonal issues, and then alcohol, other medications. It can be treated with treatments, so calcium, vitamin D, exercising, and then there's also hormone replacement therapy, but it's better to just prevent it. And some of these have pretty bad side effects too that you might have heard of. There's other drugs, biphosphonates, decrease osteoclasts, that makes sense. And then denosumab, this helps men, it just helps men that have prostate cancer. So there's not really like great options for treatments. It's better to do the eating healthy, exercising, and those things. So plenty of calcium when you're a child to get your bones really strong, reduce consumption of carbonated beverages, and exercise. Okay, Paget's disease. This is where you have weird bone deposits or resorption in weird places. So occurs mostly in the spine, pelvis, femur, skull. Usually later in life. They don't really know what causes it. It's a very weird disease. And there's some treatments, but it's rough. So here is an x-ray showing it. So just weird bone deposits in weird places. Okay, developmental aspects. We've talked about the fetus a little bit, but you can tell fetal age based on, like, since we looked at those pictures that show how the fetus grows and how the bones ossify, you can predict how old they are based on that. And then we talked about this already. You have growth plates when you're a child and adolescence, and by, depending on the person, 25, you're pretty much like as tall as you're going to be, and you're pretty much done growing, but that can vary. So there's a 12-week-old baby, and it's showing where the ossification is happening. So you're replacing cartilage with bones in those places. Okay. In children and adolescents, you are making more bones than you are resorbing them. So your osteoblasts are busier than your osteoclasts, males more than females. At young adult, they're like balanced, and then as adults, you're doing more bone resorption, and eventually that maxes out in women and leads to osteoporosis. Okay, bone density is affected by genetics. There's a gene for vitamin D, so even if you eat all the vitamin D in the world, your genetics might be outplaying you. And then bone mass mineralization and healing ability decreases as you get older. So that's part of what makes it harder, and women more likely to get osteoporosis. And we're done.